Hello, everyone. This is Dr. Susan Hudson from Texas Fertility Center with another episode of Fertility Docs Uncensored. I'm here with my amazing, talented, splendiferous co-host, Dr. Carrie Bedient from Fertility Center of
Hello.
Las Vegas,
Hey, everybody.
and Dr. Abby Eblen from Nashville Fertility Center.
Hey, everybody. I'm just wondering if splendiferous is really a word, but it sounds really good, though.
Carrie
You
uses it all the time.
But
It,
just because Carrie uses it doesn't mean it's a word, though.
I alone have used it enough times to put it in the lexicon, and it is in
Okay.
Webster's
Maybe at
dictionary.
least the Urban
So,
Dictionary or something.
Yes.
yeah, now I'm going to actually look it up and see if it is legit because in my mind,
Just
it
curious.
is and always will be.
Well, we also have a splendiferous guest, Dr. Lauren Lemieux from Forum Health. How are you doing, Lauren?
I'm great. Thank you so much for having me.
Oh, we are so excited to speak with you today. Lauren is a obesity medicine specialist. She is board certified in internal medicine and obesity medicine, and she is also a physician nutrition specialist. So she is absolutely brilliant when it comes to the stuff that we're going to talk about today. Oh, Carrie has a comment.
And I would like to mention that she is also splendiferous, which Merriam-Webster says is extraordinarily or showily impressive.
Yeah. I mean, she's in a bunch of fellowships, so she is definitely splendiferous for sure.
No, still legit splendor here.
So, Lauren, when we were talking beforehand, we were talking about your musical preferences.
Yep. Yeah. So I was sharing with you all how you may not expect this when you meet me. And it's not until I will tell people, but one of my favorite genres of music is heavy metal. And I was lucky enough to be able to actually perform playing the drums, a heavy metal song at my own wedding with my husband.
Wow.
Yeah. So it was Van Halen's All Wait, which is probably actually not the genre of metal that I normally listen to be honest. I like the metal that like you can't really understand what they're saying, but like the drums are awesome and the guitar is just like screaming. But my husband's a big Van Halen fan and he plays the keyboard. So he wanted a piece that he would be able to demonstrate his skills. And the drum part wasn't too hard for me. At that point, I was in residency, so like I had no time to practice. And it was kind of crazy. We practiced a lot, like whenever we could. I had an electronic drum set. My husband has a keyboard. And then on our wedding day, we have all these, things to get ready. And then we did a sound check with the band
And you had to
we
perform.
played it with them 3 times. And it's like, okay, good luck. And we performed well. I didn't rip my wedding dress. I didn't drop a drumstick. So it was really fun. Yeah.
That is so cool. That's so cool.
So is Kiss in the same genre as that? Would you consider them as heavy metal or not?
They are. Yeah. They're one of like the founders of heavy metal. But I mean, heavy metal now has so many different genres, subgenres. I mean, it really like when I speak to another metalhead, it's like we could be talking about 2 completely different like types of metal, but they're still called metal.
And what links them all together? What makes them metal?
Oh, that's a great question. I think part of it is just what is the makeup of the band itself. So like, you have the singer, the bass, the drums, the guitar.
Yeah.
But what's really fascinating is metal has started to expand beyond that and incorporated other things like keyboard, for example. And then there's some metal bands where they have like electric violinists. And I think there's another metal band where the lead singer plays the bagpipes. So it's like really dynamic and, it changes all the time. So it's pretty neat.
Have you heard, like, I kind of remember growing up, there were a couple of metal bands that would pair with a symphony orchestra.
Uh-huh. Yeah.
The symphony would play whatever their songs were with them. And I have spent time looking for them because that happens to be a rabbit hole that I like jumping down of taking whatever really anti-symphony music that you can and then combine it with symphony because I love how that sounds, but I can't actually find it. And I kind of remember, I think it was Pearl Jam or Metallica or something.
I thought Metallica did that. Yeah. And then of course you have like Trans-Siberian Orchestra with like the holiday music that's like a little
I don't
edgy.
consider that as metal. I wouldn't think I love that.
Yeah, some of their stuff has like real like metal riffs there. Yeah.
Huh.
So the riff that makes it more metal if there's a riff there, like a guitar riff.
Well, I mean, part of it. That's a really great question of like what makes something metal.
I
I
keep
mean, to
going, what
me,
makes
it's
it
also
metal?
like that passion and power behind it and how it makes you feel. And
Yeah,
then like of course, like if you can headbang to it, then that has to be metal, right?
gotcha. If you have to wear earplugs and your head's going like this, it's metal.
Yeah. And if you're wondering if the show you're going to is heavy metal, like just look, is everyone wearing black t-shirts? Okay, then you're probably at a
Ah,
metal show.
okay. Okay, there you
And
go.
just for our listeners, for context, Lauren looks
Not
like
like
she'd be
the heavy metal fan.
not like she'd be really at home in a library. All
All
right, do we
right.
have questions?
We do. We do. We have a question today. Hi, docs. I'm absolutely obsessed with your show and with the three of you. That's so very sweet.
Aw.
I recently found out that my Spotify app, that I am the top 0.1% listener of your podcast and feel honored. Oh my goodness, that's so
Well,
cool.
thank you.
I'm working on my weight because I know that being a healthy weight is so important. Have type 2 diabetes that I hopefully want to control better with weight loss, and I'm 37 years old. I know time is of the essence, but I also know that some fertility clinics have weight restrictions, for example, for egg retrieval. Typically, you need to have a BMI of 40. Can you speak to this? Different centers have different limitations on BMI. What can I do in the meantime? When should I go and see a specialist? Should I wait until I'm at my weight goal? Thank you. So some of this we're going to answer now, and some of this we're going to answer during our talk with Lauren.
Mm-hmm.
I would say it doesn't hurt to go see somebody, no matter what your weight is, just talk to them because different clinics do have different standards. And, sometimes you can get some things going, they can check your hemoglobin A1C, make sure how on track you are with your diabetes. Sometimes things like that really throw us off track more than the weight does. It depends a little bit on how close you are to your weight goals. But I would definitely see the clinic first, and then you kind of know what your goal is, and you guys can set a goal and figure out how to get it accomplished.
And sometimes we figure out things during your evaluation that are going to take time. And so we might as well be like, if there's a sperm factor we need to work on, since it takes 72 days to make a new sperm, it's, we can be doing multiple things at once. So we're very, averse at the, very good at doing kind of the full pronged assault. So, give us the opportunity to be looking at the full picture. I think one of your questions was why do we have BMI limits? And some of it depends clinic to clinic. So I would say, at least for our clinics, although we do have some variability in our BMI limits, it really comes down to safety during the egg retrieval.
Mm-hmm.
Yeah.
So if you have a BMI over 40 or over 45, whatever the limit happens to be, it is, quite honestly, it's harder for us to see what we're looking at. Your ovaries are enlarged. They're sitting next to very large vessels we need to avoid. And it also has issues with how hard it is for you to maintain your airway when you're under the anesthesia. So most of us are doing egg retrievals under essentially general anesthesia, but you are still breathing on your own. And so the more weight you have on your chest or your neck, the more those soft tissues are likely to kind of collapse because you're not awake to keep them open, and cause airway difficulties. And safety always comes number one. Getting you pregnant is number two. And so when it comes to safety, we just can't compromise on that.
Mm-hmm. And
Well said.
the factor of where we do our retrievals, because most of these tend to be in outpatient surgery centers attached to the clinic,
Right.
which is based on favoring the eggs and keeping them in the most controlled environment possible, because a regular, even a well-equipped hospital is not going to have the embryology setup that we need. And so when we're in these outpatient surgical centers, you just don't have the same backup that you do when you are in the hospital. So I can take somebody down to the hospital outpatient surgery center, and I can do a lot more involved stuff there because I have backup. Because if something happens, I have the entire hospital and emergency room right behind me, as opposed to if I'm out in clinic, where I tend to be really judicious about, all right, how do I keep this patient safe in the environment that we happen to be working in?
Mm-hmm.
Right. Absolutely. So with that, let's segue to Lauren. Lauren, tell us a little bit about, what you do at Forum Health and kind of how you interact with fertility patients, and then we'll kind of ask some questions from there.
Absolutely. So Form, for those of you who aren't familiar with our program, is a telemedicine obesity medicine practice. And basically, patients are paired with a doctor who is board certified in obesity medicine and their own registered dietitian, and they meet with their providers very frequently. The doctor visits are about once a month, and the dietitian visits are about every 2 weeks. So this is
Oh, wow.
really, high
Pretty
intensity
intense.
behavioral change counseling. We're supporting them with nutrition, physical activity, lifestyle changes to support them on their weight loss journey. And then me, as a medical doctor, if appropriate, might be prescribing medication. So, we'll be watching for any side effects or issues with that, monitoring their weight trajectory. But ultimately, we have patients who are referred to us actually from their fertility specialist who, go over, their medical history, and, we'll do that workup of, is there anything else that could be going on before just saying, oh, it's a weight issue. But also we'll say, hey, if we are going to go down the route of these types of procedures like you're describing, for your safety, we need to bring your weight down. And so they work very closely with us. And, when they come to see us in that context, like they need to lose a certain amount of weight so that they can have an egg retrieval, for example, the first question I'm going to be asking them really is like, what is your timeline? Because, if they're trying to, lose weight in a 6-month period, a year period, that's very different than someone who's, maybe in their like late 20s, early 30s, and might have a little bit more time to take to lose weight. I'll talk about this maybe in a little bit, or I think one of your other speakers might talk about this more when you have her on, but there are medications for weight loss that have been shown to be, highly effective, but we're talking about over the span of a year. And so, and some of these medications, we actually have to stop 2 months before a person can, go through an egg retrieval. So that's like a even more longer process. And I have to know what they're planning to get into.
So just for our listeners, if you go back a couple weeks, we talked with Dr. Florencia Halperin about all of the medications. And then a couple weeks before that, we talked with a really fabulous, hang on, I got to get the terminology right, registered dietitian. And she was just fabulous as well. Her name is Julia Axelbaum. And so we're putting this series together because at the beginning of the year is when everybody's resolutions are still strong. And so we're trying to
I'm sure you're really busy in January.
Oh, yes, it's ramping up. Yeah.
Yeah. So along with this episode, go back and listen to those other two.
So tell us a little bit about how you counsel somebody on either end of the weight spectrum, because we know that underweight's not good and overweight's not good. So how do you talk to somebody who's underweight, and what do you talk about with them?
Yeah. So for context, where I am right now, I do not see patients who are underweight. I mean, the people who come to Forum, they have a BMI of at least 27. In the past, I have worked with women who are underweight and, were referred to me because it was felt that their weight needed to actually increase to help with their fertility. And so when I'm talking to these patients, first and foremost, it's getting an understanding of what is their lifestyle like, and is their body weight something that they've always, just had a low body weight, or is this a new thing? Is this, common for their family to just be tiny people, or, is this not? And I'm sure, you also are thinking about, is the body weight too low because there's excessive caloric restriction? Is there, an issue with like over exercising, or not necessarily over exercising, but are they, an elite athlete and like training for triathlons, and that's affecting their weight as well. And I often think about, weight balance as almost like Goldilocks and the Three Bears when it comes to fertility, because, you can have too little, or you can have too much, or you can have just right. Luckily, the spectrum isn't that narrow as like temperature of oatmeal, but you get my point. And so when it comes to inadequate, body weight or body fat, I mean, your body is basically telling you, look, I don't have enough to support a growing baby. I'm just trying to support this human being, and their fertility drops is kind of how I think about it.
What about on the other end of the spectrum?
Mm-hmm. Yeah. So in terms of helping them come up with a plan for how to lose weight, or explaining to them why they're having trouble getting pregnant, which question?
Like what are some things that you advise when somebody comes in, they're like, I want to work on getting pregnant now.
Okay.
I'm not planning on waiting 6 months or a year because I've
Got it.
already been trying for 5 years, because that's going to be
Mhm.
the most common situation.
Yeah.
What are things that can have a positive impact in the short term, and is it even worth doing something in the short term?
Well, I think it's always worth doing something. For this type of patient who's, looking at very, very short term, like let's just get things going, I really put on my, nutrition hat, and I'm working on their nutrition and their lifestyle, activities. If it's someone coming in to see me at form, with excess weight, I really want to get a good dietary history, understand, is there a challenge with like appetite, emotional eating, food cravings, and really kind of hammer that down, and learn a little bit more about, are there little things that we can adjust that won't make a huge impact on their lifestyle. I'm not about, having a patient jump onto, the latest fad diet, or,
Yeah.
significantly restrict their calories where they're not eating anything. It's about how can we make these changes, but also like, let's track things. Let's make sure we can move things along, assuming that's appropriate. There are some patients who come to see me and they've done the food tracking, they've done all the writing, the journaling, and they're like, please don't make me write another thing down. I'm like, okay, that's all right. With what we do with our patients, a lot of times they'll take food photos, which is a lot easier for them, just to
Ah,
track things. And our dietitians are really great at reviewing those and giving some feedback.
huh.
And Julia probably mentioned this because she likes to talk a lot about it, when she describes our nutrition plan at Forum. But I'll also counsel patients on what we call our plating method, where we really focus on like protein to help patients feel full, and then produce to also help them feel more full, take up more space in the stomach, but not add a lot of calories. So it's really leveraging the foods that we're eating to help, promote that weight loss and induce that caloric restriction, if that's the direction that we're going in. But regardless, anything that we do, we want to make sure something a patient can sustain long term. And
Mhm.
especially, if they do get pregnant, I don't want things going the opposite direction where, they're not able to maintain the nutrition plan that we've started, and, then their weight skyrockets, or, they run into other issues, because they felt too deprived for so long, trying to lose the weight before getting pregnant.
Well,
So
what's one of the most, oh, sorry, Carrie, you go ahead.
I was gonna say, so what are some of the little tips and tricks you use for people who, like, for example, have a ginormous sweet tooth, and how do they get through that?
Yeah,
Asking for a
Okay.
friend.
that's a good one.
Okay. All right. Fair enough. So,
Asking for a friend. Yeah.
like one of the things that maybe isn't like the first direction people will go in, but like my little pearl is, I always ask about sleep habits, because what's really interesting is when we're chronically sleep deprived, the ghrelin hormone that makes us hungrier goes up, the fullness hormones go down. And I find that these patients who have sweet cravings, it tends to be like in the evening or at nighttime. And I ask them how their sleep is. They're like, oh, I get like, 4 or 5 hours. And I'm like, okay, well, do you feel pretty tired during the day? Yeah. And chances are it's like, can we give you a little bit more sleep? Like, I think this is your body telling you, I need energy. And like the sweets are what they turn to. And I find myself doing this too. And so that tells me, okay, I need to get more rest. But that would be one thing. For sweet cravings, it's also like, what does the rest of the day look like? I mean, I have some patients where they kind of get in this habit where they feel like, oh, I do so well all day and I'm so perfect, and then I just can't hold on anymore. And it tells me, well, maybe we're being a little too restrictive already. And
Mhm.
maybe you need to have some of that carbohydrate like at lunchtime, or have it at dinner. If they're just having like, protein and veggies the whole day, how your body's going to want some carbohydrates. The sweets are a pretty simple source of that. And then of course, like, some patients really like the ideas of alternatives. So we'll talk about like, what is it that's your sweet craving? So, for your friend, is there anything in particular that he or she like really craves for sweets?
I mean, she may or may not really love chocolate and ice cream.
Okay.
Dark chocolate.
Okay.
May
Yeah.
or may not. Yeah.
Okay. Got it. Got it. Yeah. And I'm also kind of curious because patients will share this with me. It's like oftentimes related to like around the time of their period where like the chocolate cravings come
Mhm.
up. And not
Yeah,
to be stereotypical, but it exists. I mean, that's a
yeah.
thing. So making sure that they're balancing out their meals earlier in the day, having a source of carbohydrate if they're, trying to lose weight. Sometimes they cut that out naturally earlier in the day, maybe making that part of that. And then if it's a certain food type or flavor, some people do well with the replacement. So my favorite go-to is like, if you like chocolate, do you like protein shakes, chocolate protein shakes? Some of them taste just like hot chocolate. Now that it's cold out in the wintertime, try a protein shake hot chocolate. It's the simplest recipe. Just micro it for like, 45 seconds, a minute. And it can really give you that chocolatey flavor, but that protein helps you feel full. And, you sip on it. So it takes some time, and it can give your body that moment of like, okay, I'm getting that taste that I really enjoy. Whereas if you grab a handful of M&Ms, they're gone in like, 10 seconds, right? So there's also like, how can we extend that flavor and enjoy it for longer? So then, it doesn't feel like you have to go back to having more and more of the candy or whatever it is.
So tell my friend that. Thank you.
Okay.
So I'm curious, when you look at the pictures of things that patients have plated, what's kind of the most common thing that you see that maybe they don't realize that they're doing incorrectly, or that could be sabotaging what they're doing?
Can I guess?
Sure, go for it.
It's not colorful enough.
That's a really good point.
I think the portions are too big would be my guess.
I was going to vote for portion sizes too.
Yeah.
Yeah. Well, the portion sizes actually are a little bit challenging with the food photos, because a lot of times patients will post a picture and then say, but I don't eat the whole thing. You're like, oh, well, what part of it do you eat?
My friend eats part of it, but I don't eat the whole thing.
Yeah. I have to agree with Susan. It's colorful and vegetables, produce.
Colorful.
Like, that's the hardest thing. And I think, as Americans, it's just, produce is really hard to come by unless it's like French fries and, tomatoes and ketchup. Like, you think about
fries, do they count?
Right. Well, they do have some fiber. There's a little more vitamin A with the orangey color, but I think it can be very hard to get that in. And so I talk to my patients a lot about like little creative things, like, hey, it's the holidays recently, so you love the mashed potatoes, great, I love them too, but can you mix in some cauliflower or something like that, which to me, like, if you do a 50-50 mix, you may not notice it. Your relatives may not notice it. Just throwing that out there.
I have a question. I had a patient this week, and this is not the first time. We have all had this patient come in before. And can you address kind of the psychological impact of obesity, fertility, and being angry at the fact that they're in that situation, and everybody has that friend who's bigger than them, who has had 4 kids, and really addressing that kind of psychological aspect of it, because it's real and it's frustrating, and it's a major challenge for a lot of our patients.
Yeah. Well, to me, when I hear that come up, what I think a lot about is just how for so many years, and probably for most of the patient's life, people have treated obesity as, a personal problem and not a medical disease, which is what it truly is. And in fact, I'll be very blunt. I feel like insurance companies look at it this way as well. Can you imagine if they were to deny coverage for, certain cancer treatments or high blood pressure or diabetes, saying it's a personal choice? Well, you decided to smoke cigarettes, now you have lung cancer. Wait, what? That's horrible. But they do that for obesity treatment. And I just get, I'm reeling it in a little bit because I get very frustrated about this, because I think it's so wrong. It's a biological disease. And so
that's kind of how we feel about fertility treatment for many years. It's the same thing. It's like, this is a disease. This affects people's lives, and they won't pay for it. But it's gotten a lot better on our end for now.
And I think it's compounded when you have someone who's pursuing fertility, and then they also are struggling with their weight, because they probably get a lot of pressure from other people saying, well, if you just lost 20 pounds, like, if you just didn't eat that,
20 pounds, you'd be fine.
They're getting it from their doctors before they come to it.
Right. Yeah.
I don't know how many people are like, well, they told me all I needed to do was lose weight, and I'm struggling and I can't lose weight and I'm still stuck.
Yeah. And for a lot of them, the patients who I see, they work so hard and they get treated like, oh, you haven't tried hard enough. Or if you just didn't do this, it's like, no, they do the same thing over and over. They diet, they, buy into the weight loss programs, they do the exercise videos. and they lose a little bit and then they regain it, and then they go back and they keep trying at it. And so I tell my patients, I'm like, look, you are like so hardworking and so determined. If this was something that you chose for yourself, there's no way you would be in this situation, because look at what all you've done so far to try to get out of it. And
Yeah.
so, we do work really closely with patients in kind of untangling that, stigma and self-blame that, has kind of been ingrained, unfortunately, by
Yeah.
society in a lot of ways. But also empowering them with some tools and support to help them start to move the needle. And then, that really gets the motivation and excitement going when we're seeing things move along. And then as an aside, like, this is a biological disease. And so for some patients, they do all the things, the nutrition, lifestyle changes, and things, barely move. And so, I do have other tools in my toolbox with medications, or, in some cases, patients will undergo bariatric surgery. I mean, there's other things we have available. So while, yes, lifestyle is a huge, important component of it, we have to appreciate that there's other tools that can help address this. And I feel very fortunate to be in the place where we are now, where
Yeah.
now we're seeing like new medications come out that are, quite effective, and, giving a lot of people hope. And, I'm just excited to see where we'll be in the next, 10 or 20 years with a disease that's so prevalent too.
I'm just curious with the medicines that are out, and I know you haven't talked a lot about these, but they say that you need to wait 8 weeks to let that kind of get out of your system. Is that just because we don't have any clue what they could do, or there have been animal studies that have suggested there's some sort of problem, or why is that?
Yeah, there are some animal studies, specifically for these injectable weight loss medications, GLP-1s, and then GLP-1 GIP receptor agonists, where there has been fetal harm to animals when they were taking the medication and were pregnant. The 8-week or 2-month washout period is because these medications have a pretty long half-life. It's about 14 days, or 10 to 14 days in some cases. So we just need to let that medication completely get out of the system before a patient, is going to undergo the egg retrieval or become pregnant, for safety purposes. But then, unfortunately, we also find that, patients with these medications, they can become more fertile, and, things happen.
Catch 22.
So we always counsel our female patients who, can get pregnant, that, hey, we need to use some form of birth control, and, this is what to expect if you are planning on getting pregnant, for a timeline. That's why I mentioned earlier, like, that's why that's so important, because, 8 weeks is a long time to wait if you've already been waiting.
Yeah.
Go ahead, Susan.
We both want to ask something. So I wanted to ask a question regarding kind of the other half of the population, also known as men. So, I mean, I can tell you when, I have a couple come into my office and they walk in and he easily weighs 350 plus. I am definitely having some little palpitations, worried about his swimmers. Okay. How do you treat, do you treat men when it comes to obesity and fertility? And is there any difference when it comes to what they can do and can't do when they're undergoing their fertility treatments?
That's a really great question. So I actually have one patient on my panel whose wife is going through fertility treatment, and I think she's pursuing IVF. But regardless, I think weight loss can be beneficial, especially if there's, metabolic complications of the excess weight. And again, for clear context, like, I see patients who have a BMI of like 27 or higher with a weight related medical condition. So like, that's the kind of patients I'm talking about for weight loss specifically. We know that, excess weight in one parent can increase the risk for, metabolic disease in the child, long term. So I'm thinking about that. But for their swimmers, weight loss can be helpful. I will say not a lot of men, ask me specifically, like, or share with me like, oh, my wife's doing fertility treatment, I want to, lose weight for that. I don't think I've had anyone like bluntly say that. But I should probably ask about that a little bit more. And then, for their treatment though, like, ultimately it does, involve these main pillars of, nutrition, physical activity, lifestyle changes. From a medication standpoint, for my practice, There's one medication, metformin, which I don't know if you guys are familiar with this study
Oh
that came
yeah.
out, but there's some concern about, I think it was like genital abnormalities in the children that were born to men who had taken metformin at the time of conception. So I just stay away from that medication if, my male patients are planning on, having kids. So that's where this conversation might come up. But otherwise, I do have a little bit more freedom in terms of other medications if we're going to go down that route.
Do men need to wait for the GLP-1s to have a washout, or is it really just kind of the in utero exposure for women?
We think it's the in utero exposure. I haven't seen anything in the prescriber information that men need to wait. It's only directed or recommended for women.
As a general rule, when men are heavier, though, don't they tend to have a little bit higher estrogen levels and lower testosterone levels, which could, I
Yes.
guess, impact sperm?
Yeah. And then, kind of jokingly, but I think this is relevant, as part of our, foundation of lifestyle changes for weight loss, it's going to be increasing physical activity. To prepare for this lecture, I did read that, biking is not so good for sperm count. So like that might be the one exercise I tell my male patients, maybe don't go into that as your sport of choice to get more active, but anything else I think is fair game.
Yeah, I actually saw that in a patient. He was training for, I think, a half marathon, or I guess a triathlon, because he had a bike part of it. And we saw over the course of like 3 to 4 months, his counts just started going. And I asked him what the problem was. It wasn't his count so much, it was motility. And he was doing a lot more extended time biking because the friction in the seat impacted the sperm.
Is there an impact that changes when on the kids? So if you've got a parent who's never been overweight, a parent who was overweight and lost it and then got pregnant, versus someone who is still actively overweight, like, do we know how much of a difference that carrying the extra weight and losing it makes compared to the people who don't lose it?
So I'm not aware of any studies. Granted, this isn't something I've actively looked up myself, but why I think this is still, important is this concept of, we have the genes that we're born with, right? But then how they are expressed is actually directly influenced by the environment that we're in. And so, when the thought is that when a baby is, developing in utero, in a mom who has excess weight, now that excess weight is affecting the expression of certain genes that then increase the baby's risk for, let's say things like excess weight, diabetes, heart disease, like years and years down the line. But, we also appreciate that, obesity, for example, is so multifactorial. So it's not just that, it's also, it's influenced by whether or not the mom had a C-section or a vaginal birth. Did she breastfeed, or did she, use formula? And so there's all these little pieces that go into it. So at the end of the day, like, while we try to optimize the environment as best as possible, I think there's certain things that maybe we can control or we can help with, and other things where we just kind of do the best we can in that environment.
Can we come back to this like C-section, vaginal delivery, breastfeeding?
Yeah.
Can you give us a little more information on that?
Yeah, so there's been some observational, or I guess would you call them retrospective studies, looking at the risk for obesity in offspring, where a child was born via C-section versus vaginal. And what's really fascinating is it's thought that, a baby's gut microbiome is largely influenced by the bacteria that it's exposed to when it comes out the birth canal.
Vagina, yeah, absolutely.
Yeah. And so, it's just kind of like one of these really fascinating pieces of research looking at how the microbiome affects weight balance long term. And obviously you have no control how you were born, like neither does your mom really, right? So I just think it's like an interesting fact, but in what I do, if that's how you're born, that's how you're born. These are the cards we're dealt. Like, let's address some of the other factors. But it does highlight just how amazing the microbiome is, and also how little we know about it.
Yeah, it'd be interesting if you knew what the issues were, and then maybe you could replace the bacteria that the gut didn't have or needed or whatever. That's interesting.
That's definitely the hope for like years down the road, but definitely don't go out and buy those probiotic supplements thinking you're gonna, completely reset your microbiome, or, spend hundreds of dollars on the stool testing, because the science just isn't there yet.
Oh, okay. Interesting.
In that study, did they happen to control really well for the weight of the parent in both the vaginal and the C-section group? Because the other complicating factor is that overweight women are more likely to get a C-section because they're more likely to have failure of progression in a vaginal delivery, where kid just doesn't want to come down and out because of the physics, I guess, is what it boils down
Yeah.
to. But did they control for that really well? Because that's
I would,
that's a
I mean,
risk
I'd
factor
have
by
to look at the
itself.
study, but
Retrospective,
I
she
would,
said.
yeah, I would think they'd have to at least, in their analysis, make sure that they're trying to eliminate those other variables that could play into it, like, the BMI of the mother, for example, because we know, her BMI is going to increase the risk for obesity as well.
Mhm. Huh. Okay.
That is very interesting.
So, Lauren, what other words of advice would you have for our listeners who are starting off this new year and wanting to have a baby and potentially, maybe get their weight under a little better situation? What would be a couple of good pointers?
Okay. I think, first and foremost, at the bottom line, you're hearing it from a medical expert here. We're all in the agreement that this is a biological process. It's not, a willpower issue. It's not a personal, thing that you've decided for
Shortcoming.
yourself. There's other things that go into this, and there are medical providers out there who can and want to help you and address it from a medical standpoint, and not, try to sell you things or, try to get you to follow the latest fad diet, only to have you fail and then, go through the whole process again. And so I think understanding that we have a lot of compassion for what you're going through and it's not your fault is really important to go into that. The other thing is, how can I best support my body is what can I do and maintain long term? So again, it goes back to that idea. I don't want you, trying to follow a keto diet if you hate eating meat, right? Like that's not sustainable. And so finding things that work best for you. And it is unfortunately, a process, and there can be, trial and error. And sometimes it really helps to work with someone, who is experienced in this field and get that support. So if you've been thinking about, hey, I've done this a lot on my own, maybe it is time to reach out and get that extra help. Because, there's people like me out there who love to help patients, and, it's not easy to do on your own.
Yeah.
How do you advise patients, particularly who want to get pregnant, who do go on something like a keto diet and they find that it works for them? Because when I think of keto, I always think of the full word ketoacidosis, and I'm thinking about,
Yeah.
we don't really want a pregnant woman in an acidotic state.
No,
And so
definitely not.
do they need to deliberately stay off those keto diets once they are pregnant in order to facilitate good development of the baby?
Yeah. So to my knowledge, any sort of like ketogenic diet is not recommended in pregnancy. I mean, the baby needs the carbohydrates, and we don't typically advise even a low carb diet in pregnancy either. Even for our patients with gestational diabetes, you're not asking them to go, super low carb. And so, yeah, I think it is a challenge. If you follow something like that, you lose a bunch of weight, and now your doctors are going to tell you that's not healthy for you while you're carrying the baby. What's going to happen with their weight afterwards? Well, some of it may come back, and that can be distressing.
All right. Well, thank you so much for visiting with us and giving us all this great advice, and really make the point that, whether it's fertility or obesity, these are medical issues. These are truly medical issues, and there are people like all of us to help you kind of guide your way through this maze that you find yourself in, and we're happy to be there for you. So to our listeners, thank you so much. Be sure to tune in next week for more, and be sure to subscribe and leave us a review. Would love to hear from you. We're also on Instagram, Facebook, YouTube. Follow, subscribe, and stay updated.
You can also visit fertilitydocs.uncensored.com to submit specific questions you have about infertility. All questions will be answered on our Ask the Doc segment, so don't hold back. We love episode ideas, and we want to know what you are thinking.
And as always, this podcast is intended for entertainment, not a substitute for medical advice from your own physician. Thanks for listening. We'll see you later. Bye.
Bye.